All attendees are in listen-only mode.
And about 2/3 of cancer patients will actually receive radiation as part of their treatment. Of that, 2/3, or 75%, is curative in nature. And that means about 25% is palliative. This is also very rewarding for you as well. Radiation can be given definitively as the primary treatment with or without cancer. It can be given before surgery or after surgery. And radiation is also given for benign diseases. So prophylaxis of other prostate cancer, or keloids, or Dupuytren's contractures. So there's some other various benign diseases. We don't use it that commonly anymore, largely because now we know that it can cause cancer. So at the heart of the question, what is radiation? Well, the Merriam-Webster definition is the process of radiating, which is probably not a great definition. But the process of emitting radiant energy in the forms of waves particles. That's really the true definition. And then kind of what is radiation therapy would be the process of emission, transmission, and absorption of radiant energy. So really, in the patient, what we're concerned with is the absorption. So my patients ask me, what is radiation? It's just high energy x-rays. It's the same x-ray that comes out of a chest x-ray that we give in therapy. But radiation ultimately, I think when we use that term, what we imply is that it's ionizing. So ionizing radiation means that the energy is high enough to knock an electron on orbit, and that's changing bonds. And so ultimately how radiation works is that it's working through DNA damage. So this can be directly, the photon can come in, interact with the electron directly in the DNA atoms, and cause single-stranded or double-stranded breaks. Or we know that the majority of the cell is made up of water, and so 2/3 of the way radiation works is actually indirect DNA damage. The photon will come in and it will actually split water and it creates a hydroxyl radical. That hydroxyl radical is actually very reactive, and that in turn interacts with DNA and causes DNA damage. This is what predominates at the conventionally fractionated, so the longer course of radiation. When we do brachytherapy or some shorter courses of radiation, there are some cellular level processes that go on. So why does radiation work? Well, the simplistic view is that we point the radiation beam at the tumor. Tumor cells do not repair DNA damage, but normal healthy cells do repair DNA damage. And if that were true, then why doesn't radiation always work? Well, radiation doesn't always work because the body gets in the way. So in radiation oncology, it's a very fine line between tumor control and toxicity. And for every cancer site, that's a different balance. And for every patient, that's also a different balance. So in reality, I can give very, very high doses of radiation. The problem is that they may be around a critical structure, and that's a problem. So radiation is different from other cancer therapies. How is radiation different from other cancer therapies? Well, it's a local treatment similar to surgery. But it's non-invasive, except for brachytherapy. There's no sanctuary sites. So with chemotherapy, we worry about the blood-brain barrier, or in leukemia patients, the testicular barrier. And in oncology nowadays, there is a new trend towards targeted agents. And so what are these agents targeting? Well, they're targeting a mutation in a pathway. But cancer cells are kind of sneaky, and so they find a way around that pathway. Because the DNA damage from radiation therapy is random, there's really no evolving cellular mechanisms to render radiation ineffective. So when we talk about radiation, on the one hand, there's electromagnetic radiation. This is photons, gamma rays, that also includes microwaves, radio waves, that type of thing. But really what we think is that photons and gamma rays, again, are ionizing. And then there's also particulate radiation. And just sometimes you hear gamma rays and gamma rays. A gamma ray is just defined from nuclear decay, so it comes from the nucleus. Photons can actually be generated from electrons or other particles. And then in terms of particulate radiation, most commonly electrons are used. There are some proton centers in the US. And then there's really no active alpha particle therapy. Neutrons and heavy charged particles, they have these centers in Japan and Switzerland. The grand majority of patients are being treated with photons in the US. So a couple of different forms of radiation. So the primary form that most of your patients are going to get is external beam radiation therapy, or teletherapy, meaning distance. The older units are the cobalt-60 units outside of Mexico and India. You probably won't see this anymore. 90% or so or more of patients are being treated on a linear accelerator, and we'll go over what that is. And then if they're getting protons, they're getting treatment with a cyclotron. So if you think about protons and electrons, an electron, it maybe takes about 4 feet to accelerate to generate photons. But an electron compared to a proton's about 2,000 times the size. So in order to use proton therapy, you basically have to have a football field size in order to accelerate a proton. So subsequently, up until about 3 or 4 years ago, there were only 8 main centers in the US. And then brachytherapy, brachy meaning close, so this is radiation that's actually in the body. This can be in a cavity, like a lumpectomy cavity or the vaginal vault, or it can be interstitial, such as prostate cancer. It can be temporary or permanent. And high dose rate and low dose rate is just how long the radiation is active in the body for. And then the last form that often falls in nuclear medicine is injectable radionuclides. So this is radioactive iodine, samarium, radium, that type of thing. So most of your patients are going to be treated on a LINAC, that's a linear accelerator. And real quickly here, there's a magnetron that generates RF. And there's an electron gun here that spits off a little electron. The RF accelerates that electron, and then we bend it, and it hits a target. That target is generally tungsten. After it hits the target, it generates photons or X-rays, and this is what has been coming out and treating the patient. Inside the machine here, it says a collimator. Old school, I used to draw a block. We would have would be about 8 inches thick of a Cerebend solution. The radiation therapists were very fit, and they would put that block into the head of the machine. But nowadays, this is all done electronically. So we have these little, what we call MLCs, that move in and out and can shape individually to each patient. So patients will often ask me, oh, do I need to wear lead, or how are you going to protect me? And all of the blocking is done within the machine itself. And then if we wanted to treat with electrons, electrons have a negative charge. They're not very penetrating, so they're often good for skin cancer. So the easiest thing to do is that we just take out that target. When the electrons come out, they bend around and then come straight through. But we still may need to shape them, and then we do use an external block here because electrons, again, aren't as penetrating. That block is only about 1 inch thick of metal. So this is just kind of what we call the vault. The vault is where patients are getting treated. It's feet of concrete. And so this is just a picture of our vault over at CUC. So the patient would lay on the table here. We call this the couch, actually. And this is the gantry. So this is the top of the machine. This is where the radiation comes out. This will rotate around the patient. This is for localization, and this computer doesn't necessarily control the machine, but it's for the therapist to make sure the patient is in the right position, the machine is in the right position. And then we have video monitoring and an intercom system. What the patients can't see is this is actually a false front. This allows the room to be slightly warmer because a lot of times they may be slightly undressed while they're getting treatment. And then, oops, I'm sorry about that. Behind the machine, this is actually the guts of the machine here. And this allows that room to be kept at a cooler temperature. And this is actually our magnetron here. The reality, though, most of the cooling of the linear accelerator is done with water, and so a main water supply is very important. So I want to spend the rest of the time today on the patient experience, kind of go through it from the eyes of the patient. And so this is just kind of the care pathway, video consult, simulation. Patient goes home, we do the symmetry, quality assurance, and then their treatment and follow-up. So patients come to see me, and they spend 30 minutes with my nurse. And then they'll spend 60 to 90 minutes with myself. So they're often spending 2 hours in my department on the first visit. The main point of the consult is, should we treat the patient? Are they healthy enough for radiation, or are they unhealthy enough for surgery that they need radiation? Or, it's kind of individualized to every patient. If we decide to go ahead with treatment, we have to educate them on the side effects. We also have to prep the patient for treatment. So prior to planning for our head and neck patients, we have to get their teeth out ASAP because we can't even start the planning process until we get their teeth out. For other patients, we have to think about before we start their treatment, do they need concurrent chemotherapy? Do we need to get a line and then a report? Do we need to get them into physical therapy? Is this a sarcoma patient where we're going to be worried about scarring and fibrosis and range of motion? Do we need to get them into speech pathology? Do we need a feeding tube in these patients? Will they be able to maintain their nutrition during this time? So we also have to think about how to go about putting in some of these. This patient, we've decided we're going forward with treatment. The patient then comes back for a simulation procedure. This is another 60-minute appointment. There's 2 goals to the simulation. One is that the patient is in a reproducible position. So the patient has to be comfortable. We're trying to get arms out of the way. Sometimes you're laying on their back, sometimes they're on their belly. We're trying to immobilize them as much as possible. And that's to decrease motion, so we're trying to minimize motion or account for the motion. And then the second reason for doing the CT scan is we have to place what's called an isocenter. The reality is I can use any diagnostic scan to treat a patient, but my machine won't know where in space the patient is, which sounds kind of funny. But if we go back to our treatment room here, we can see that there are 2 side lasers, and then there is a ceiling laser. And where these 3 points converge is at what is defined as the isocenter. Now, when the patient is in our planning room, there are the same set of lasers in our planning room. Where those 3 lasers fall on the patient is the isocenter, and what we do is we put small tattoos where those lasers are. They're about the size of a freckle, but they are permanent. So I'm just going to go through some pictures of some of how we treat patients. So this is a head neck patient. What you can see is the patient is in a mask. This is a thermoplastic mask. We heat it up and it becomes flimsy. We stretch it over the patient. As it cools, it hardens. There's a couple of things. We keep the shoulders very low. The chin is up. And you can see here, the 3 points will fall on the patient. This is another head neck patient. Similar, we need to immobilize the patient so that they're not moving around. However, she had an oral tongue cancer. The oral tongue is obviously a mobile structure, so not only do we have to immobilize the outside of her, we have to use a mold to immobilize the tongue. We're often using contrast with these scans. Depending on the body part, we may be using IV contrast, PO, rectal contrast, or other markers to help us. These are some breast patients. I often put wires on the breast patient here to help define some of the tissue or the external marks, such as the lumpectomy incision that you're not going to be able to see on the CT scan. On this side, we have a left-sided breast cancer patient, and what you can see here is she has a belt around her. During our treatment, what we'll ask her to do is take a deep breath in. That belt will measure her circumference so that she's in the same position. What taking that deep breath in does, it brings air into the lungs, it pulls the heart back and down, and allows us to slide our radiation in easier. Radiation does not like skin folds. We tend to get pretty good skin reactions when the skin is folded on top of itself. And so for women with very pendulous breasts, we will actually put them in the prone position. This gets that separates the skin folds. And in radiation, our goal is often to treat a solid block of water or a square block of water. And this nicely helps pull that breast into a better shape, easier shape for surgery. This is a chest patient. Now, this patient's going to undergo stereotactic body radiation therapy, which is just a few treatments. And so when we're doing a few treatments, we want to try to, again, minimize motion. And so the way we do that is we use a compression paddle. We would not do this for a lung cancer patient that was going to be getting treatment every day for 6 weeks or so. But since this is only going to be a few days, we do try to dampen the respiratory motion as much as possible. The other thing that we can see here, this is a camera, and there's a little box that sits on the patient, and we can measure their breathing cycle. We then sync up their breathing cycle with our CT scanner. So a standard chest CT would be about 175 slices or so. When we sync up with their breathing, we ultimately scan the patient kind of in phases, and we generate about 2,500 to 3,000 slices. What that allows us to do is we generate what we call 4D CT scan, so your standard ant, post, soup, in, left, right, but then we can also get time, so we can get motion. So we can actually see the tumor. This is very helpful. Tumors don't just move up and down. They do move a little front to back as well as left to right. And every tumor is going to move slightly differently. So this is a patient after surgery. You can see there's a little bit of a surgical clip right at the bottom there. This actually doesn't move all that much. This patient is another lung cancer patient, and he's going to get treatment over 6 or 7 weeks. And if I stop this right, what you can see is this is in the lower lobes. There's a lot more motion in the lower lobes than there is in the upper lobes. And if we did a standard free breathing scan, we may actually miss the lower extent of this tumor here. So this tumor actually comes all the way down. If we did a standard free breathing scan, the diaphragm of the liver may obscure that the tumor is coming that far down. This is a pelvic patient, and this blue is an alpha cradle here that helps keep the patient in the same position every day. The one thing that we try to avoid as much as possible is pelvic tilt. Classically, patients at the time of the planning simulation are very nervous. Their butt is clenched. Then they get onto the treatment machine. They're a few days into treatment. They realize, gosh, this isn't so bad. And they tend to relax, and we get this pelvic tilt that can be very difficult to account for. And we'll talk about that again. This is a rectal cancer patient, and he's actually prone here, and he's laying on a board, and then this is a cutout. We call it a belly board, so that his belly will fall forward. Being very anatomically oriented, rectal cancers, I have to know regional drainage and back patterns. And they drain to the internal iliacs. Internal iliacs dive posteriorly. The external iliacs are anterior, but in rectal cancer patients, standard rectal cancer patients, we don't need to cover the external iliacs. So we can put the patient on their belly, pull the small bowel away from the rectum, and that allows us to slide our radiation easier. Motion isn't only in the chest, it's also in the pelvis. We have to be very aware of bladder filling. This is an MRI of a cervical cancer patient that you can see here. And so when the bladder is full versus empty, that can change the shape of the organs very much. And we'll kind of circle back to this. Extremities can be very difficult to set up. Hands are a little bit easier, or arms, I should say, are a little bit easier. Sarcomas of the thighs are extremely difficult to set up properly. We're trying to separate the legs as much as we can, trying so that we can get more beam angles so that we can treat them, spread out the radiation a little bit easier. We need to cover, usually have very long incisions. We sometimes have to tape the genitals to the side, but we also want to make sure that it's in a very reproducible position. So sometimes what sounds kind of easy, oh, it's a leg, can actually be very difficult. So that was an hour-long procedure. The patients then leave, and I tell them to come back in a week. And they're like, what, a week? What goes on in a week? For some of our simpler plans, it would be a few days. For some of the more complex, it could be a week or more. And for emergencies, it'll still take us about 3 to 4 hours in order to treat a patient. During this time, we're often fusing the CT scan that we've done with MRIs or PET scans, just to help aid and to define where the tumor is. And then I will sit down and I will contour and I outline targets. One is the gross tumor volume. I then will put an expansion for the clinical target volume that accounts for microscopic disease. And then I also put an expansion on for our planning target volume, and that takes into account inter and intrafraction motion. Nowadays, with 4D CT scans, we can generate an internal tumor volume that takes into account the intrafraction motion, and it allows us to have a smaller PTB. And then I'll outline all the organs at risk. So I'm going to go through an actual patient, and what you can see here, this is a squamous cell carcinoma of the supraglottic larynx, and this is our CT scan that we've done, planning scan. You can see the IV contrast, the chin is up, the shoulders are down. There's a little slider bar over here on our actual software, and we can fuse this with a PET scan. And so that way we feel good that the tumor that corresponds well, and can we define lymph nodes in other areas. And then I put a microscopic extension, a clinical target volume on, and I respect normal anatomic barriers such as bones here. I'll then put a planning target volume on this to account for motion. And even sometimes tumors can swell a little bit, or patients can wait. And then in neck patients, I want my gross tumor to get the highest dose. But I know that even on a PET scan, if a lymph node isn't bright, there's still a risk of microscopic disease in the surrounding lymph node regions. And so I will target an intermediate risk. These are at intermediate risk of harboring microscopic disease. Again, it stays within anatomic barriers. And then I also define a low risk of microscopic disease. And so these are just getting different doses. So the low risk would be lower down in the neck here. We put a planning target volume, again, counting for motion on all of those. And we're not done yet. We have to contour in all the normal organs. So we're contouring in spinal cord, constrictors, esophagus, mandible, optic nerves, chiasm, lenses, oral cavity, brachial plexus. So we're going through and literally trying to contour everything that we can. Some of those organs we're actively trying to avoid. Some of them we're just documenting the dose that they're getting. This was a patient, a 20 young lady. She had neuroblastoma when she was a child and had only one kidney left and had renal cell and didn't want surgery. She wanted dialysis. So we treated her with radiation, and again, just in terms of motion, what you can see here is that we would miss the top of this tumor if we weren't able to be able to fully see the motion. So I just think these pictures are really cool in general. Again, that patient had compressions to dampen the tumor movement. So treatment planning, now we have all of our organs outlined, and so there's two kind of major types of treatment planning. One is 3D conformal or forward planning. So I would pick the beam angles. I will also outline the beam shape, and then look at constraints. So this is a left-sided breast cancer patient, and what you can see here, this is what we call free breathing. The heart tends to be up against the chest wall. You can see especially in this here, with deep inspiratory breath hold, it pulls the heart back just a little bit and down and allows us to slide our radiation in easier. This view here is called the beam's eye view, so it's coming from the direction of the beam, and you can see we can avoid the heart entirely. This is another patient. She didn't need free breathing. She had enough distance, and sometimes patients anatomically don't need that. Also, what I think is fun, we again try to treat square blocks of water. Because the radiation there's less tissue. If we think of the breast as kind of triangular, there's less tissue out here. There's more tissue along the chest wall. As radiation goes through, it would be very hot out here. So we can use what we call wedges, and that makes up for the tissue deficit here, and ultimately tries to make that shape back into a square. Prone, again, we talked about how radiation doesn't like skin folds, and so if we lay the patient prone, it pulls the breast away. Even though this is a left-sided patient, it's very heart sparing. You can see here the heart is not in the field really at all. The other part of treatment planning, so we put some beams on, we like the shape of everything, but we want to make sure that we're reviewing the normal structures, again, heart, lungs, depending on where we are. And we want to make sure that there's good tumor coverage, there's no cold spots where we're underdosing tumor, no hot spots where we're overdosing tumor. So this is a lung cancer patient, and it can always look very complicated when I first sit down. We actually chose 6 different angles for this patient, trying to entirely avoid the right side of the chest. And what we can see ultimately in his plan is that we look at different metrics for different organs, and for the lung in particular, we look for the V20. That's this dark blue line here that's outlined. And we're entirely avoiding the left side of the chest, and the upper right side is well spared. Again, this is a dose volume histogram, so we can see that our target coverage is over here. This would be, I think, esophagus and lungs, esophagus, and tongue. This was that prone patient. Again, it allows the small bowel to fall anterior or inferior, I guess, if you're thinking about it. And the mesorectum is still well covered with radiation. So that's kind of 3D, tends to be a little bit more simple. And then there's IMRT, which is intensity modulated radiation therapy. This is actually poorly named. We can still modulate the beam or adapt the beam in 3D conformal, but at the heart of IMRT is that it's inversely planned. So instead of me putting a beam in a certain angle and then looking at it and maybe changing it, I do the opposite. I say, I want my target to get 70 gray, but I only want this carotid to get 26 gray. I don't know the best way to do this, so computer, you figure out how to move these MLCs in a way that I'm sparing as much as I can. So on a head and neck patient, these are some of the more complicated cases. This was a tonsillar lesion here, and what you can see is the radiation is being pulled in or around the carotids here, but we're still getting a very high dose to the tumor. It's also sparing the spinal cord. And anytime we're trying to, the mandible, we always worry about the mandible as well. Anytime we're pushing a lot of dose around, we can always get a little bit of hot spots. I'd say maybe 5-10 years ago, it would be very common to get a 10% or maybe even a 15% hot spots in IMRT. Nowadays, my goal is really around the 5 to 7% range. So our techniques have also improved. Again, we're looking at dose volume histograms. These are the carotids. This is the spinal cord. Obviously, there's lots more organs on here that isn't shown. So that was IMRT. So it's kind of stepwise. The machine, the leads move in and out, kind of. But we can actually move all the way around the machine. And so if we think about the beam kind of going around a target, and this isn't the best video, but those leaves can kind of move around as the machine is moving around the patient. So this is a prostate cancer patient. IMRT or VMAT, volumetric modulated arc therapy, tends to spread out the low dose a little bit, but it is very good at making the higher doses fall in a lot. So what you can see here, the rectum is very well spared, and so this is a very, very conformal treatment. In radiation oncology, we also struggle with obesity. This patient had prostate cancer and his BMI was, I think, 45. Even though we have our table limits is 450 pounds, this patient was only, I think, 370 pounds, and we have a wide bore CT scanner, we actually cut off his tissue here on the edges. And so radiation, we need the Hounsfield units or that tissue density from CT scans to be able to treat through it. So we could not treat through these angles. Unfortunately, these are kind of some of the best angles because it avoids the rectum and the hips here. So we did the best we can, and it's still a very good plan. It's still falling in nicely, but we definitely struggle with obesity as well. Just one word on stereotactic body radiation therapy. It's maybe the 60 gray that we give over 6 weeks. We give it in 3 to 5 days. What this takes is a small target that we can accurately target, or a small tumor that we can accurately target. And what you can see again are the isodose lines, or where the dose is falling off very, very rapidly. And this allows us to spare much more of the normal tissue. Okay, so we're through the treatment planning. I'm happy with the plan, and now the question is, how do we know what we plan to deliver is what we are actually going to deliver? So the first thing that we do is a second verification of our treatment planning system, and it's a little bit of a more basic algorithm, but we pick a single point here, so this is a head and neck patient, and what we look at, this says MU, so if we go back to that definition of radiation, what I'm prescribing is gray or centigrade. That's an absorbed dose in the patient. The machine cannot necessarily tell me the gray. That depends on how big something is, if it's tissue or bone. But it can tell me the monitor unit. That's the energy that's coming out, and it's measured by an ionization chamber. So when we do second calculations, often we talk about the monitor units. So what you can see here is these beams are very, very close, and because this is a kind of a little bit more of a basic algorithm, we allow up to 5%. But from some of our more intricate techniques, we will actually deliver the plan on the machine prior to the patient getting there. So we have a flat unit called a map check, and instead of just checking one point, it's checking 1,500 points. And so my physicist will come up with a little summary here and says that 98.9% of the points passed. What we're actually measuring, though, because it's a three-dimensional treatment and it's a 2D planar check, is the fluence. And so what we get out are fluence maps. So what you can see here is there were 894 points checked, 8 of them failed. That's 99% of them are passing. And the blue that may not show up very well, these are where the points failed. So when we look, we are measuring the circles are what's measured on the map check. The line is actually what's planned. You can see it's just a little bit further off on that blue dot. This is still very accurate. We accept up to 97%. So how is treatment actually delivered? So in general, it's daily, Monday through Friday, anywhere from 4 to 8 weeks. Stereotactic body radiation therapy and brachytherapy are only a few days, so they're kind of an exception. We give them a 15-minute appointment. We spend 10 minutes of that time lining them up properly. The machine is on only maybe 100 seconds or so. During the treatment, patients don't see anything or hear anything. It's not painful. I take that back. They do hear the machine buzzing and ticking. When the machine stops ticking, the radiation is off, so they're not radioactive. I see them once a week on treatment to see them regularly and come up and see if they have any side effects. My nurse and myself are there every day. If there's anything, often we see them multiple times a week. So these are our control rooms. This is where the radiation therapists sit. Again, we can see and hear the patients at all times. This is for the linear accelerator control room. This is for our brachytherapy control room. In brachytherapy, you can see that's the gurney in the room there. I often will give conscious sedation for some of the more painful procedures, so we can also monitor their vital signs remotely as well. Of course, radiation has to be complicated, so this machine and controller here control the actual treatment unit, the LINAC, and then this machine controls this one. And so I have a couple of videos. This first one is a left-sided breast cancer patient. So you'll hear my therapist tell the patient to take a deep breath in. You'll see that that circumference, it's in the red zone. The red zone is good. And then if you pay attention to the green square, you'll see that some of those leaves are starting to move in.
Can you take a deep breath and hold it?
Machine is on. Patient is in the red. Leaves are moving.
Go ahead and breathe.
And then you can see it goes back down into the green. This one is a lung cancer patient. It's a faster dose rate. So you can hear the machine is running faster. It's hard to see, but these leaves are actually moving. You may or may not be able to see that the machine is rotating around the patient. So often as the machine moves, it'll slow down just a little bit to make sure it doesn't get ahead of itself, I guess you could say. So the last video, again, this is just real-time imaging of the leaves in the machine. What you can see is that they're going to move. You can hear the machine actually moving in the background. So what you notice when you don't hear as many of those clicks coming out, that the machine is trying to avoid whatever is in that area, and then when it starts going at a faster dose rate, it says, wow, this is a really good angle, I'm going to pump more dose through this way, but I'm going to avoid this way. So my therapist gets to listen to that annoying ticking all day long. So again, kind of a similar question, how do we know what we plan to deliver is actually what we deliver? And we take pictures. So in radiation, the therapeutic dose is in the megavoltage range. At that level, the Compton effect dominates, and that's independent of the Z or the density of the material. So often soft tissue will look very similar to bone. This is actually a thin patient, so this is a good example. Sometimes if we get very large patients, it's just all gray. And so, yeah, you can see, I can see the iliac crest here and the femoral heads, but up here, I can't really see the spine. So if we go back to our machine, if we can produce megavoltage range photons, we can produce kilovoltage range. So nowadays on most machines, 90 degrees opposite, we have an imager. And so this is from actually our CT scan. It's called a digitally reconstructive radiograph. So it takes the images from the CT scan and makes it into an X-ray. And then we take a picture with that kilovoltage of the patient actually on the machine. And now, because the photoelectric effect dominates in the kilovoltage range, bones become very prominent. You can see, spine processes through the bowel there. I'm very happy that things are lining up. What's hard to show you, of course, there's a little slider bar where the images are overlaid on each other, so you can slide it back and forth. This is what I see when we're checking patients for alignment. So the DRR is tiny bit fuzzier than the KV image. This patient we moved a millimeter to make sure they were in the same position. Now, if we can get an X-ray out of our machine, what if we just kept that X-ray on and rotated 180 or 360 degrees? Well, then we would generate what we call cone beam CT. Now, these are not, these images aren't as high quality. Again, it's still not a diagnostic machine. But what we can see is we can see internally the actual organs. You can see here the bladder's not quite as full. The rectal filling and bowel is fairly consistent, though. And there's a couple of different ways. This is purple is planning, green is patient on the machine, and when they overline, it tends to be white, especially in the bones, so it feels good to see everything aligned well. Or we can just look at the cone beam and have my contours on, or there's a little bit like a checkerboard, so we can move it around. In the lung, it's very nice to be able to see our tumor right in the middle of our target. The other thing that I had talked about a little bit before, our machine does correct for pitch, roll, and yaw, which is pretty cool. So especially in the pelvis, we talked about that problem with pelvic tilt. It's very difficult to correct for in your standard supine upright and post directions. So now we have this cone beam CT. If we took that cone beam CT and we kept it on for a slightly longer period of time, and we refiled that information, we can actually generate a 4D cone beam CT on our machine. So this is the patient actually on the machine, so this is real time. And what you can see is this is that big lung tumor. Okay. There we go. And you can see it actually moving up and down. Now, this patient was actually halfway through their treatment, so their tumor is actually shrunk. But again, it makes us feel good that what we actually seeing and targeting is truly with the patient on the machine. So side effects. I'd like to spend the rest of the time on side effects, because this is, again, probably what you guys are most interested in when you see patients. It depends on the volume treated, the total dose, the dose per fraction, the time span that we deliver those fractions, and then if they've had concurrent chemotherapy or prior radiation, and then the tissue type itself. So 30 gray delivered over 15 fractions of 2 gray per fraction is very different than if we gave 30 gray over 5 fractions of 6 gray per fraction. And then very similarly, giving 5 days in a row is very different than giving 5 treatments over 2.5 weeks. So we have lots of radiobiological models that take into account all of this information. I love radiobiology, but I would be happy to give another talk because I think most of you probably are interested in that. The tissue type. So we have 2 classic types of tissues in our body that radiation oncologists see anyways. One is serial. So if you think of the spinal cord as a serial structure, if any one part of that tissue doesn't work, the whole organ doesn't work. The other is parallel. So in our lungs, we can tolerate very high doses of radiation to the lung. That lung won't work, but we have reserves. So the lung and the liver, we have reserves. So those are parallel tissues. So serial tissues are very mostly affected by the high doses. They can tolerate medium doses very well. Parallel structures they're very affected by high doses. Parallel structures can tolerate high doses, but it's those medium doses spread out over the whole organ that cause us problems. So we generally divide side effects into acute, which is during treatment or the first 3 months, and then long-term side effects, those are generally 3 months or more. Short-term side effects accumulate over weeks, and they actually peak after radiation finishes. So I'll always warn my patients about this, but classically, I know they do this. A week after they finish, they call up their primary care doctor and say, I'm having a lot of nausea, or my skin is, it's raw and red. So I warn them. I do want them to come back to see me. Short-term side effects tend to affect rapidly dividing cells, so skin, gut, mucosa, and it tends to be an inflammatory effect. The other side effect is fatigue that all of our patients get. So this is just kind of a list from head to toe, and it's not all-encompassing, but in the brain, often fatigue. The other thing is that we do have some nausea centers in our brain, as well as our stomach. If I'm not treating the brain or the stomach itself, or the liver can be a little nauseating. It's unlikely that I'm going to cause nausea to the patient. We can cause hair loss, and hair loss is in the treatment field. So when we're treating the brain, obviously we can cause hair loss. And otitis, or a muffled hearing, head and neck, parotiditis. They get dry mouth. They can even sometimes get a little bit of pain or inflammation in the parotid. Thick saliva and phlegm. They lose their taste. They get mucositis or sores, depending on where we're treating. That can happen anywhere from the mouth down into the throat. Again, this can be incredibly painful and also cause problems swallowing, a laryngitis, a hoarse voice, skin, erythema, dermatitis, desquamation, and we'll talk a little bit more about that. In the chest, we can cause a little bit of a dry cough, esophagitis, or heartburn, or painful swallowing. Pericarditis is pretty rare nowadays. Gastritis, nausea, vomiting, diarrhea, in the pelvis, a cystitis, a frequency or urgency, prostatitis, a sense of pushing, slow stream. You can cause tenesmus, diarrhea. If patients are having painful bowel movements, it actually tends to be from an inflammation of hemorrhoids. And then in the extremities, again, skin or lymphedema and joint stiffness. Now, in reality, we actually don't worry that much about acute side effects. They actually tend to heal fairly well because these mostly are affecting rapidly dividing cells. So taking an extra moment on skin, whatever happens from the radiation is going to happen. We tell them to use moisturizer, fragrance-free moisturizer, prophylactically to decrease dryness and pruritus, but it won't necessarily change the course. If they're going to get desquamation, they're going to get desquamation whether or not they're using lotion on their breast. And we have done lots of trials. We actually have a meta-analysis on some of this stuff. No product is superior to another. The most recent one to come out was emu oil. It just doesn't make a difference. Moisturizers and topical anesthetics. So if we get dry desquamation, so it's kind of flaky, we can use topical lidocaine. Otherwise, if we get moist desquamation, so it's more like a blister, then we'll use Silvadene. Silvadene is a barrier as well as slight antibiotic property. And the key there is making the patient comfortable. So it's very interesting. Post-mastectomy patients, post-vulvectomy patients, we've done surgery, we've cut their nerves. They actually don't feel a lot of this desquamation. If they're not in pain, we keep going. However, canal patients, they haven't had surgery, they feel a lot of this painful sunburn on their bottom, and then they're pooping or having diarrhea over it, so it's miserable. So severe pain is a reason to stop. If they're not having pain, though, we try to keep going. And then kind of classically, I will see an endometrial patient who's overweight, and I've told the patient, we are treating more internally, we're not going to cause any skin reaction. But the patient has talked to her friend who's had breast cancer, and she got a terrible sunburn, and she knows that she's going to get sunburn. So she starts putting her lotion on day one. It's the first or second week of treatment. She comes to me, she lifts up her panties, and it's raw and red, and she's like, Dr. Proper, what are you doing to me? I can't make it through treatment. This is awful. Well, I'm actually not doing that to her. That is a yeast infection. We need to keep the area dry, and we still need to maintain hygiene. So not every patient will get a skin reaction, so we always want to be wary and make sure they don't have a secondary bacterial or fungal infection. And just recently I had another breast patient the first week of treatment, and she ended up having a zoster outbreak during her radiation. Again, same thing, it was in just a band, and she's like, Dr. Gruber, I can't make it through treatment, this is so painful. And well, actually, let me treat your viral infection. So most of the side effects are acute or late. There are some intermediate side effects, and radiation pneumonitis and radiation necrosis are a very similar process. It's really inflammation. But it tends to happen in a short period after radiation, often peaking around 4 to 6 months after radiation. Sometimes we see this on scans, and if the patient isn't short of breath, we don't do anything, because about half the time it may go away on its own. But half the time, 2 weeks later, they come back and they say, you know what, I'm coughing now, I'm short of breath. Unfortunately, you have to give high-dose prednisone. So traditionally, we prescribe 1 milligram per kilogram. I usually start at 60 milligrams. And it has to be a fairly long course, so we're doing it for at least 3 weeks, and then you have to taper by 10 milligrams per kilogram. So it's often, and it always seems to happen in diabetics, and so you're struggling with their sugars and stuff like that. Radiation necrosis in the brain, is a little bit funnier. It can still happen even over a year out. But again, same thing, if we see it on imaging and they're not having any problems, we just observe if they're starting to get headaches or whatever neurologic symptom that brought them in originally, we start dexamethasone, and again, we slowly taper over about 2 months. Interestingly, bevacizumab is a VEGF inhibitor, and it's to normalize the vessels. And so bevacizumab is actually FDA approved to treat radiation necrosis. And then just kind of an aside, in a large GBM trial, it wasn't shown to be beneficial in terms of treating cancer, but in a recurrent GBM trial, it did show a benefit in overall survival. And I almost wonder if maybe they were treating a little bit of radiation necrosis in that recurrence. Sometimes it can be very hard to differentiate between tumor recurrence and radiation change. They both look very nasty on scans, and patients can get symptoms from both. So if in a last resort, the bevacizumab, the steroids aren't working, we have to take them back to surgery, remove that dead tissue basically that's causing that inflammation. The other intermediate side effect that we see with Hodgkin's patients is actually Lemierre's syndrome, and so it's kind of interesting because it's in a very moderate dose of radiation and it's in younger patients, but it's like electric-like shocks down into the arms traditionally, so maybe almost like a myelitis of the brachial plexus. Long-term side effects. So most of them are the result of scarring and then secondary cancers. So in terms of long-term side effects, again, just a head-to-toe list here. Cataracts takes very little radiation to cause a cataract. So even head and neck patients where we're treating more down here just because of a little bit of scatter, warn them about cataracts. Neurocognitive decline. So in patients outside of primary CNS lymphoma where radiation in the elderly can definitely cause a dementia, we're very weary about that nowadays. Outside of that situation, when we're giving radiation to the brain, we don't really cause a dementia. We affect 3 main areas. One is word finding ability, short-term memory, and processing speed. These are normal signs of aging in the brain. Radiation accelerates that aging in the brain. Just within the last couple of years, for whole brain patients, Namenda has been approved to help decrease the chance of loss in those 3 areas, mostly in the verbal recall, and then Aricept with partial brain radiation. The Namenda trial, I think we might have just actually been treating a little bit of underlying undiagnosed dementia, but I offer it to my patients. Endocrinopathies, visual deficits, hearing loss, again, radiation necrosis. Not every patient is going to get all of these side effects. Unfortunately, it's very dependent on volume and anatomy where the tumor is. Head and neck patients, they get xerostomia. And then, so bones in general are a little weaker after radiation, so their teeth aren't as strong to begin with. We then dry out their mouth. Saliva is very good at washing away bacteria, and so when their mouth is dry, then it sets them up for even more dental caries. So head and neck patients, we want them going to the dentist religiously, fluoride treatments, cleanings, that type of thing. If it gets to the point where we need to pull a tooth, we very much worry about osteoid necrosis, and we'll talk about this again in a second. Dysphagia. We can cause scarring in the muscles of the throat and cause permanent dysphagia. We're doing better on this nowadays, but there's still a low chance of that happening. And then hypothyroidism. In the skin, hyperpigmentation, thickening of the skin, permanent hair loss in the treatment field. In the chest, again, stricture, scarring, fibrosis in the lung, possibly causing shortness of breath, small vessel disease in the heart. Decades ago, we used to cause some electrical abnormalities and valvular problems. We really don't do that type of heart treatment anymore, so the most common thing that we would see is pulmonary artery disease. In the abdomen, we always worry about ulceration, and so we're very limited on dose in the abdomen. Most commonly, what I see from patients in the abdomen and pelvis is chronic irregularity. We can see changes in bowel bladder habits, kind of funny. Sometimes prostate cancer patients who have BPH after the radiation, they actually start to pee better. We've caused a little bit of shrinkage or scarring. That obstruction has been relieved. And then, unfortunately, if that process continues, though, we can cause a urethral stricture, and then obviously we have problems peeing, and we have to send it back to the urologist to open that up again. And then women, sometimes stress incontinence can get better because we cause a little scarring. Sometimes it can get worse because if that scarring is in muscle and the muscles aren't contracted properly, then incontinence can get worse. Vaginal stenosis, we'll talk about rectal bleeding and fistula in just a second. And then extremities, lymphedema, joint stiffness, decreased range of motion. And the name of the game in terms of long-term side effects is trying to prevent as much of this as possible. So getting them into physical therapy right away, working on that range of motion, if there's any swelling, compression therapy, speech therapy. There are some studies with pentoxifylline and vitamin E. I think they're hit or miss. I usually try it as a last resort if a patient is really complaining of scarring. There was some positive US data. So patients, if they need a dental extraction and had high-dose radiation to the mouth or head or neck area, will often consider hyperbaric oxygen. This is a little bit of a balance. Within the first couple of years of radiation, we're always worried about tumor recurrence, and so we don't want to be giving high doses of oxygen and feeding those tumor cells, but at the same time, we want to make sure that the healing is best as we can, and that includes high doses of oxygen. Radiation, often in terms of vessels, it's causing scarring along those small vessels, so the blood flow isn't as good. And then I want to see my patients back, so if they're ever having a problem, send them to me. I want to know what's going on. I may not always be able to help them, but I have a few things. A couple of things to remember, it's a diagnosis of exclusion. So if you have a pelvic patient or a woman who comes in 3 months, 6 months after radiation and they're complaining of diarrhea, we want to make sure they don't have CDF or irritable bowel or some other things. And then kind of this first do no harm. So when we're giving high doses of radiation, those tissues don't heal as well. Actually, let me take a step back and talk a little bit about timing again. So prostate cancer patients, they've had radiation 7 or 10 years ago, and now they're having rectal bleeding. We're not thinking that that's a problem from radiation. We're worried that they have a colon cancer or rectal cancer. So, however, if that same prostate patient comes and it's a year or 2 after their radiation and they're having rectal bleeding, then we're thinking this is because of radiation. Radiation irritates the rectum. The rectum recruits new blood vessels to help bring in sugar and glucose. Those new blood vessels are friable. Stool comes down. You end up having blood in your stool. So the first thing that we do is often conservative measures, steroid enemas or citalopram. But sometimes the bleeding may not go away, and we need to take a look and see what's going on. For any of you out there that are doing procedures, biopsies are necessary, but try not to biopsy too much because the radiated tissue just doesn't heal very well. JAMA only publishes negative things about radiation, and so there was recently a case report of a patient with lung cancer and had a bronchial ulcer. So the lesion was very close to the main stem bronchus. They did a bronchoscopy and they biopsied that ulcer, then turned into bronchopulmonary fistula, and the patient died. Now, why this got into JAMA, I have no idea. But I do know that biopsying in radiated areas can cause problems. I don't know, that patient that might have happened anyways with more time, but maybe if we had tried to avoid the biopsy, maybe it wouldn't have happened. So, in just a moment on secondary cancers, so there's some criteria. I think there's really only 3 criteria. 1, the patient was actually irradiated. Sometimes patients it's funny how much they don't know about their own history. 2, a cancer of different histology than the origin, so it's not a recurrence. 3, it's in the radiation field. Some people will put a latency period of criteria in there. It used to be 7 years, and it was 3 years. I think that's silly. 6 months, 9 months, whatever. Radiation can cause another cancer. I think a year out is a cancer and 10 years out. So, and then all of these late effects that I just talked about do not apply to the pediatric data. Peds is an entirely different, unfortunately, different situation. Obviously, their bodies are growing and dividing during this time, where ours are not. So they have a lot more late side effects, and secondary cancers are very important in these children, especially breast cancer patients with Hodgkin's, where we're radiating breast tissue. They have very high rates of breast cancer. However, kind of in the more adult world, a chance of a secondary cancer is about 0.2% to 15 years. This was just recently published in JCO, and it's a long-term follow-up of the Swedish TME trial and the PORTEC trials. Of course, these are European trials where we can follow patients for 15 to 20 years. Both of the trials are non-smoking related cancers, so that's always important when we're looking at patients.
And both of the trials in the rectal and uterine cancer were plus or minus radiation, so fairly simple 50-50 plus or minus radiation. And what you can see here is that this is all comers. There's no difference whatsoever between the risk of a secondary cancer. What should surprise you, though, is that at 15 years, 26.5% of patients without radiation and 25.6% of patients with radiation had a secondary cancer. That number is huge. To be fair, they did track non-melanomatous skin cancers in these patients, and so about half of these are from basal cells and squamous of the skin. But still, if we're thinking 12-13%, so somebody who has an endometrial cancer, they still have a fairly high rate of a secondary cancer. And then all cancer patients had a hazard ratio of 3 for developing another cancer. So I think this is my last slide. I follow up with my patients regularly. I'm often alternating with a medical oncologist or surgical oncologist. In the short term, we're seeing them more often. As they get further out, we tend to see them less and less. I think it's great when we alternate because everybody has a slightly different view of what we're looking for. When I'm seeing patients, I'm often thinking about, are there some things that I can prevent or treat early, hypothyroidism, or get them into physical therapy. Screenings for other cancers, especially smoking-related cancers. Heavy smoker drinker with head and neck cancer, inevitably they'll come back with a lung cancer or esophageal cancer or bladder cancer. These are smoking-related cancers. This is individualized to the patient, though. So somebody with a locally advanced lung cancer, I am not talking about mammography. So I do individualize a little bit. And then the last thing, in oncology nowadays, we are also struggling with obesity. And so I'm constantly harping on my patients to exercise and maintain a healthy body weight. We have more and more data coming out that obesity plays a role in inflammation and in tumor progression. So obesity has been shown to be a risk factor for breast, endometrial, colon, rectal, myeloma, Hodgkin's lymphoma, bladder. I think there's even a handful more. So there's definitely lots of cancers out there that we think are increased by being overweight. So thank you so much for your attention. Sorry that I went long, and I'm more than happy to answer any questions. And or if there's interest, I would be happy to give a talk on the history of radiation or radiology or a specific cancer, or delve more into science.
Okay.
I just wondered, can you talk briefly about radiosensitizing agents that are given prior to, and what's the benefit, when would that be used?
So there's two kind of classic ones. One is amifostine, and we use these in head and neck patients. Radiosensitizing in the fact that we're trying to decrease long-term reactions to amifostine in head and neck patients. Unfortunately, it can cause pretty much severe nausea, vomiting, and hypotension, and it has fallen out of favor. And it was really to protect the carotid. Now that we have IMRT, we're doing a better job of protecting the carotid. The other one was mirtazapine. We use these in cervical cancer patients. There was a benefit. It's not used all that often, and the reason is because as mirtazapine was coming about, we then switched over to chemoradiation therapy. So in general, radiosensitizing, we're often using chemotherapy. Chemotherapy will selectively, or is supposed to, selectively increase the cancer cells and their sensitivity to radiation, and hopefully not damage as much of the normal tissues. So there are many cancers nowadays where we're using chemotherapy along with radiation therapy. Chemotherapy can be given in high doses, kind of systemically every couple of weeks. Often when we give it for radiation in the head and neck or with cervical or anal canal, we're often giving kind of a weekly, actually anal canal is not weekly, but a lot of times we're giving it weekly. This isn't to prevent distant recurrences, it's to make the radiation work better. Unfortunately, we do know that that does increase acute side effects. Mucositis in head and neck patients is definitely worse. Same with anal canal and cervical patients, diarrhea and desquamation in canal patients. Again, that balance between tumor control and side effects. Acute side effects, we actually worry less about. They do heal. It's those late side effects that we worry a little bit more about. So we're more willing to give them acute side effects. We're more willing to put in a feeding tube up front to get them through the treatment because we know that they will heal on the back end.
Oh, gosh.
That's okay, they only just left.